एकदम शॉर्ट हेयर लॉन्ग कोट एकदम वो वाला इन्फ्लुएंसर वाला लुक। इसने बात करनी निखिल भाई बात कर लीजिए। इसकी बड़ी वाली बहन होगी छोटी इधर साक्षी थी और उसकी दोस्त थी उसका साथ निखिल की बहन। हाँ उसका नाम साक्षी है।
We can start the class.
Okay, thank you, Tina. Thank you, team Maharashtra. Let us start. Diseases and clinical conditions of elbow, wrist, ankle, and foot. First of all, we are going to elbow joint. Relating with the anatomy, elbow joint is a complex hinge joint, consists of three joints. The three joints are one, humeral-ulnar joint. This is humerus, and this is ulnar. You can see, and humeral-radial joint is there. This is radial head, and here there is annular ligament. This area is seen in this picture, annular ligament, which holds the head of the radius in position. It is very important in the aspects of injuries to elbow joint. Then proximal radioulnar joint. Here is another joint, this proximal radioulnar joint. And this is capitulum. Capitulum articulates with the radial head, and trochlea articulates with the ulnar. Tennis elbow. This is one of the common conditions that come across our routine. This is a lateral epicondylitis. Etiology is a repetitive strenuous activity. Clinical picture is acute or chronic onset of pain. Here is the point of pain or tenderness considering the tennis elbow. This is the common extensor attachment point, that is lateral epicondyle, and inflammation at this point or in the muscles or tendons may result in tennis elbow. There is a test called Will's test. The patient is sitting in position and the wrist is passively palmar flexed, and pressure is applied on the lateral epicondyle. Here the physician is applying pressure on the lateral epicondyle, and there will be pain in case of tennis elbow. One important point is that rule of any shoulder weakness with a patient complaining tennis elbow, because shoulder weakness causing further load to the extensor compartment muscles of forearm and causing thus leading to tennis elbow. Management of tennis elbow is anti-inflammatory drugs can be used like Amrutotharam Kashaya, Pajanamrutam Kashaya, Vettumaran Guliga. Initially we can give Vettumaran Guliga. Jorahara treatment also found useful in tennis elbow management. There is Vettumaran Guliga, Amrutotharam Kashaya, Pajanamrutam Kashaya, Amrutharistam plus Punarnavasam are very good. And then we can start the Vadaraktara or Vadahara Kashayas like Rasta Saptagam, Rasta Panchagam, Rasta Nirdavi, like that. And Ektamosha by Kapil is very good, found very good. And Atmigarma in the most tender points, Atmigarma and Ektamosha can be done. But how to determine whether our patient is fit for Atmigarma or Ektamosha? We can use ice cube or a hotted shalaga here, and place the blunt part of the shalaga to the lateral epicondyle. And if the patient is having more complaints or worsening the complaints, then we shouldn't do that Atmigarma there. We can apply Ektamosha there. And if there is Upashaya or Anupashaya is testing here. And we can use tennis elbow brace. This only helps to relieve the complaints for temporary, not for the relief of the disease, but relief of temporarily relieve the pain. Then coming to Goldfield's elbow. Goldfield's elbow is counterpart of tennis elbow. It is affecting the medial epicondyle. It is always called medial epicondylitis. And here the pain is experienced at the medial epicondyle or the common attachment of flexor tendons of the forearm. Test is just press on the medial epicondyle with flexion of the wrist. The wrist is flexed and flexor boosted and just press on the medial epicondyle. Then pain will be there. Ectomosha is found more effective than actinorma in Goldfield's elbow because more Vadarekta condition is seen in Goldfield's elbow compared to tennis elbow. The next is student's elbow or olecranon bursitis. Inflammation of the bursa or the olecranon process. Pain, tenderness, and swelling will be there. Here we can see the redness and swelling. In adults, rule of gout because it is one of the sites of accumulation of gouty tophi. Gouty tophi may be accumulated in the Goldfield's elbow region, olecranon bursa, and severe pain will be there. So, rule out uric acid problem, that is gout, in the patient with the student's elbow. This is also a Vadarekta condition. Anti-inflammatory drugs like Amritotra, Pajanamrita, Punanamadi Kashaya can be given. And labas, especially Vadarekta laba, that is Jadamayadi, Nagaradi laba, also found useful. And Tiluga Jarna is found useful in student's elbow. Then coming to the arthritis of elbow joint. Refer acute monoarthritis, especially in children, because it may be a septic arthritis. If it is septic arthritis, the clinical features are redness, fever, and we should do blood test in this condition and raise CSR above 80 and CRP above 20 will be there, and refer the case because the septic arthritis need antibiotic treatment. It is difficult to manage by our conservative method. And rule of TB in arthritis. TB is not uncommon in elbow joint and marked swelling of the elbow with muscle wasting. The muscle wasting is important in case of TB. And evening rise of temperature will be there. Blood test and biopsy will help us to rule out tuberculosis of elbow joint. Then coming to OA. OA we can manage, but if locking by loose bodies is present, it should be removed surgically. So we should refer the case with locking of elbow joint. Treatment of osteoarthritis. The two kashayas found very useful are Rasna Panjaga. It can be given initially and then Rasna Randadi. Maharasnadi Gugulitaga are also found useful. Then after that, the patient having acne and we can use Snehana by Gugulita Gruda or Carpus Taila or Shirabala, Mahanarana Taila, Dhanundara Taila. If the patient is Vadaputta Prakriti and more lean patient and having Daknibala, we can use Grita. Gugulita Grita especially found useful. And Carpus Taila, if there is associated shoulder weakness or cervical radiculopathy, we can use Carpus Taila. Shirabala is more anti-inflammatory. And Mahanarana Taila, if severe pain is there, then use Mahanarana Taila. Internally, we can use 10 drops PD dose is enough. And Dhanandara Taila is also a Brahma Taila. If muscle wasting is there, use Dhanandara Taila. And Nastya with the Carpusasthya Taila initially, or 6 or 8 drops in each nostril is found useful. Then we can use Gandha Taila. Gandha Taila Nastya is very useful in osteoarthritic conditions of upper body. And Anvasana with Dhanandara Taila. Then coming to rheumatoid arthritis of elbow joint. While examining a rheumatoid arthritis patient, we should take an X-ray and take care about the joint length. There will be uniform loss of joint space. Look at this X-ray here. There is uniform loss of joint space is seen, and this is typical of rheumatoid arthritis. And management is Deshamula Shiradara. It is useful in painful conditions of Vadarakta or rheumatoid arthritis. And Anuvasana with Madhyashtha. If Budakti is there, then you can use Madhyashtha Pana, 10 drops bleeding with suitable Kashaya. Then Shiravasti. Shiravasti is one of the important chilsa considering the Vadarakta. And Jelugavajana locally will relieve the pain and tenderness. Coming to the injuries of elbow joint, there are three important points while we considering the injury of elbow joint. The 3 points are lateral, as we see in this picture, lateral epicondyle, olecranon process, and medial epicondyle. In normal position or extended position, these 3 points come across in a line, and in flexed position, these 3 points form almost a triangle shape. If there is severe injury or displacement to the bony parts of elbow joint, the triangle will be disrupted, and we can examine the patient by taking an X-ray and rule out any bony dislocation, bone injury, that means dislocation or fracture. Coming to dislocation of elbow, it is called the posterior dislocation of elbow. That is, here the dislocation is happening to the olecranon process. Olecranon is dislocating. In this picture, it is clear. The mechanism of injury is fall onto outstretched hand with the elbow slightly flexed. Seen more in 20 or 10 to 20 years of age group. Then management is reduction. Reduction, there is 2 methods. Push-raise technique for children and pull-raise technique for adults. Push-raise technique is very simple. Patient in prone or sitting position, push the olecranon with our thumb. Just push the olecranon with our thumb. Patient in prone or sitting position, push the olecranon with our thumb. Then pulling technique. Pulling technique is used for adults, and pulling the forearm in 70-degree flexion with counter traction on arm. Ask the bystander to hold his arm, and then we should pull his arm, keeping the elbow in 90-degree flexion, and the joint will be reduced. Take care of coronoid fracture. Coronoid process will be fractured. This is the coronoid process, as we see in this picture. This is coronoid process. Here, no fracture is there, but there is chance of coronoid process fracture because of the friction of this humerus over this area. So, take care of coronoid bone. Always look for coronoid process fracture in elbow dislocation. Then coming to the complications of elbow dislocations are ulnar nerve injury. Also, radial and medial nerves may be injured. Then treatment is bandage with sling. The bandage, should it go beyond 14 days, because there will be stiffness in the joint. Rebandage on 7th day. Total 14 days bandage is needed. Then coming to importance of springing test. In this X-ray, we can see a hairline fracture, an undisplaced hairline fracture here in the radius. But we may miss this in X-ray. So in every patient with an injury in forearm, we should do springing test to rule out any fracture of radius or ulna. This is done by just pressing the humerus and ulna together by our hands. The physician can use his hands to press the ulna and radius together. If fracture is there in any point, in any area of ulna or radius, pain will be there. Care should be taken for that. We shouldn't press on the tender points. This type of fractures, we can do springing test and detect the fracture site. Then coming to beam stick fractures. Beam stick fractures are common in ulna and radius, and here we can see a beam stick fracture. This is a case of radial beam stick fracture with a slight or first degree epiphyseal injury. Simple bandage with muruvana and a sling for 5 days or week is enough, and give anti-inflammatory drugs. This is another case. Here the beam stick fracture of radius is clear. Coming to olecranon fracture. The olecranon is fractured here, and the important point related with the olecranon fracture is that here is attachment of tricep muscle. Triceps is a powerful muscle, and pull of the triceps will cause the upward movement of the olecranon fragment. This fragment will be moved upward. So reduction is not easy in case of olecranon fracture. So we should refer the case for better treatment to the patient, and internal fixation is a must in olecranon fracture. Otherwise, there will be a gap and the joint movement will be difficult in future. So always refer olecranon fracture. Some of the undisplaced fractures we can manage, but it's very difficult. So please refer olecranon fracture to a surgeon. Here we can see the olecranon fracture is managed by internal fixation. Then coming to radial head fracture, the clinical features are tenderness of the radial head, and supination and pronation movements will be painful because while supinating and pronating, the radial head move, and it will be difficult for the patient. Then we should take an X-ray, AP and lateral. If we have doubt about a radial head fracture, we can take additional views, that is AP full pronation view and AP half pronation view to visualize the radial head. This is type 1 fracture. This is just a crack fracture. This is displaced fracture, type 2, and this is a comminuted fracture. And coming to treatment, conservative treatment is good only for type 1. This is type 1 fracture, just a crack fracture is here. We can manage conservatively. Bandage for 2 weeks is enough. Then type 2 fracture, this type should we refer the patient for internal fixation. This case, the management is done by orthopedic surgeons by excision of the radial head. That is, comminuted fractures management is excision of the radial head. And then coming to coronoid fracture. In this X-ray, we can see the coronoid is fractured and displaced. So it should be referred. But this case, look at this coronoid process not displaced, fractured but not displaced. So we can manage conservatively. This is internal fixation done. This is graphical. representation. And then coming to pulled elbow. Pulled elbow is otherwise subluxation of radial head in children. The mechanism is clear here. Suddenly pulling the child's arm in a supinated position. The mechanism is clear in this picture. Pulling the arm in a supinated position. Then the radial head is subluxed from ulnar ligament. We already explained the ulnar ligament is holding the radial head in position. And by pulling the arm, suddenly pulling the arm, the radial head is subluxed from this joint and ulnar ligament may be torn. Management is rapidly, it is easy to manage pulled elbow, rapidly pronating and supinating the forearm. We should take an X-ray before that to rule out any other fractures. And rapidly pronating and supinating the forearm will reduce the subluxation, then apply a sling. Don't worry about the reduction. Spontaneous reduction usually occurs within 48 hours. And 1 week sling is enough for pulled elbow. And coming to myositis ossificans, it is post-traumatic ossification. We can see here the joint space is ossified. Here the joint is ossified. This is usually by after a fracture or dislocation. And here hematoma forms under the stripped periosteum and is invaded by osteoblasts and calcification occurs. And calcification occurs also in muscles. Here, this is brachialis muscle. This is calcified brachialis muscles. And in this case, the joint is fixed to a particular angle. Treatment conservative. If there is a severe stiffness, we should refer the case. But it is if it is somewhat small degree of stiffness, we can manage. Rukshanam by Dhanyamladhara or Churna Bindasweda. We can use Kolavaltadi Churna for Churna Bindasweda. Then after Rukshana, the important aspect of treatment is Snehavan. Snehavan with the Carpal Taila. And at the same days, we can use Matravasti. Matravasti is with Dhanyamdara Taila. And this fulfill the Snehapanam effectively. That is, Snehana will be more effective when we are using Matravasti with internal Sneha. Then Shodhanam Virajanam with Dimbamrita Arandam is very good. And then Patrabola Svedam, then Kayasegam with Ashavanna. Ashavanna is one of the medicines produced by Shantigiri Pharmacy. It is very good to reduce stiffness. And also we can use Panjamala Taila or Muruvanna for Kayasega. Then coming to wrist joint. Wrist joint anatomy, the importance of wrist joint is that there are 8 carpal bones. Carpal bones we can see in this picture. Scaffold, lunate, tricutal and small pisiform here. Then trapezium, trapezoid, capitate and hamate. Then coming to the ligaments of the joint, we can see radial collateral ligament. That is a lateral ligament, and medial collateral ligament or ulnar collateral ligament, and radiocarpal ligaments are there. There are several radiocarpal ligaments. And coming to decurvence tenosynovitis. Clinical feature is pain and difficulty in movements of thumb. Pain in holding and lifting heavy objects above the shoulder level. This condition is common in feeding mothers and diabetic patients. This decurvence tenosynovitis. In this condition, the covering of the tendons of extensor pollicis brevis and abductor pollicis longus is inflamed. Here, note the tendon. Here, the covering of the tendon sheath is it's a common covering for 2 tendons, and this is inflamed. And there is a test to rule out the this decurvent stenosynovitis, this Finkelstein's test. The patient is asked to clinch the fist, and then we are giving an ulnar deviation to the wrist joint. Patient is asked to clinch the fist with the thumb inside like that, and ulnar deviation is given. Then there will be severe pain in this area. This is called Finkelstein's test. And management, coming to management, rule out hypothyroidism. Hypothyroidism is a significant factor related with recurrent stenosynovitis and carpal tunnel syndrome. So rule out hypothyroidism. Then we can use Pajanamurdam Kashaya initially and Chandraprabha Guliga, Kanjanara Gugulu, Vittumaran Guliga, Shirabala Thaida. Shirabala Thaida is found very useful. It is having high anti-inflammatory activity. Then Guglu Titta Kashaya. Then bandage and Nagaradi Levam in acute cases. If the case is acute, then use bandage with Murugana or Danadra Thaila and or Nagaradi Leva or Karatavat application. This is found very useful. And Apnirma found effective. Only do Apnirma in chronic cases, not in acute cases, only do chronic cases. Then here we can see 9-point Apnirma. The skin in this area is thinner than other areas. So we should take air while doing Apnirma. This peripheral Apnirma is enough. Don't go deep in this area while doing Apnirma, because the ulcer formation is a complication of Apnirma in this condition. So take care of the wound. Then coming to carpal tunnel syndrome, this is an entrapment neuropathy of medial nerve. In this picture, we can see the flexor retinaculum and the medial nerve. And inflammation and thickening of the osteofibrous canal. This is the osteofibrous canal here, and it is the thickening of the osteofibrous canal, setting the stenosis of the canal, and the medial nerve is entrapped. And the 3.5 fingers supplied by the medial nerve will affect. Hypothyroidism and rheumatoid arthritis are triggering factors in carpal tunnel syndrome. Investigation, confirmatory investigation is NCS. Otherwise, we can diagnose it clinically. There will be paresthesia, pins and needle sensation, numbness, weakness in the 3.5 fingers supplied by medial nerve, and difficulty and pain in flexing fingers will be there, and thenar wasting, thenar muscle wasting can be seen in chronic cases. In this picture, we can see thenar muscle is wasting because of the chronic carpal tunnel syndrome. Coming to management, manage hypothyroidism or rheumatoid arthritis or diabetes mellitus. Diabetes mellitus is an aggravating factor considering carpal tunnel syndrome. Then coming to management, Guda Ardraga Prayogam, that is explained in esophageal inside. It's very useful in entrapment neuropathies like carpal tunnel syndrome or cubital tunnel syndrome or tarsal tunnel syndrome. Guda and Ardraga are taken, Ardraga Sarsa and Guda are taken in equal amount and consumed in early morning in the empty stomach. And we can increase the dose day by day as in Vardhamana Prayoga, and we can take it up to 14 days. It is found very useful in carpal tunnel syndrome. And Kanjanara Guguru, Chandraprabha Guliga, Amurdashtam plus Puranavasam initially will give good results. Brahatyadi Kashayam, then Carpocystite Thylum internally. Also we can do Nasya with Carpocystite Thyla. Then Nagaradi or Karatavat Lepam. Then Manjal tree. Manjal tree is having very anti-inflammatory properties, and in initial stages of carpal tunnel syndrome, we can use Manjal tree. And Ektamosha or Aknikarma we can do accordingly. Then coming to recta moxa, this cupping is done in this patient. The point of application of recta moxa or acneuma is important. It is above the carpal tunnel and it is just lateral to the midline of this joint. And we can do recta moxa by cupping. Also, in this point, we can do apnigarma. Apnigarma, recta moxa, only one sitting is enough or two sittings. But apnigarma, considering apnigarma, 3 or 4 sittings are required. Here we are using cupping instrument for recta moxa. It's very easy to use. Apnigarma, shalaga is useful. And coming to ganglion, it is a cystic swelling containing gelatinous material. It is mostly originates from the capsule of a joint or tendon sheath. Repetitive trauma or degeneration may be the cause. More prevalent in women, sometimes painful. If it is painful, we can remove surgically. And here the ganglion cyst is removed surgically. There is a stalk and body of cyst, and it's removed surgically if it is causing severe pain or cosmetic problems. And coming to RA, it's the X-ray of the RA patient. It's RA. And then another disease is Kienbock's disease. This is avascular necrosis of luminate bone. Here you can see the luminate bone is shrunken. You can see the luminate bone is shrunken in this X-ray. And avascular necrosis of luminate is commonly seen in 20 to 40 years age males. Etiology is unknown, exact cause is unknown, but microtrauma or ischemia is considered as the causes. And sclerosis initially happens, then the bone collapses. Investigation point of view, the MRI or CT is best rather than X-ray. Then management, surgical shortening of the radius to reduce the compression across the lunate. Here, the radius is applying somewhat pressure to the lunate bone. So, surgical shortening of the radial head to reduce the compression will be helpful. Then coming to our management, Snehavan, Shodhanam and Thailadhara. This line of treatment will be helpful. Snehavanam is a must in case of, in any case of vascular necrosis. Snehavana is a must. Then we should do Shodhana. After that, Thailadhara and Thaila can be taken indirectly. Genda Thaila or Carpal Thaila or Dhanandar Thaila found useful in avascular necrosis. Then coming to radial nerve palsy. Radial nerve injury results from an acute trauma or compression of the radial nerve. Here we can see the path of radial nerve. In radial nerve palsy, either it is happening by pressing the shoulder across a chair or crutches. So it is called a Saturday night palsy after drinking alcohol, and the patient is sleeping on the chair, and this will cause the radial nerve palsy, and the resulting is wrist drop. In this patient, we can see wrist drop. This is a temporary paralysis of radial nerve, and the wrist drop is seen here. Coming to treatment, Shobhara treatment is applied here. Abhyanga and Ushmaswada of shoulder and arm will reduce the pressure effect on radial nerve and reduce the symptoms. Coming to trigger finger, this is one of the common condition. Here, the finger is locked in a flexed position. The root cause here is inflammation. Inflammation of the tendon and the retinaculum. The tendon is forming a nodule here, and retinaculum is also inflamed and causing stenosis of the retinaculum. So, when the patient tries to extend the finger snaps. Finger snaps like this because of the nodule passing through the retinaculum. This is called trigger finger. And management is Shophara Amahara treatment, Sneha Prayoga, Shirabala form useful in trigger finger, and Apnigarma is very useful. We can do Apnigarma or Tabasala. This is not an Apnigarma picture. This is a picture after surgery for trigger finger. But the importance of this point is that we can do Tabasala or Apnigarma here. Here is the pulley or retinaculum is situated. Here, we can apply Tabasveda by an iron hammer. After applying Thaila, we can use an hot iron hammer to give Tabasveda here. Tabasveda repeatedly over 1 month or 3 weeks will give sufficient results. Or we can do Apnigarma weekly, 3 or 4 sittings may be needed. Then coming to injuries of the wrist joint. There is an important structure considering the injuries of wrist joint that is called TFCC or triangular fibrocartilage complex. This is a cartilage and associated ligament structure, mainly a cartilage, a central triangular fibrocartilage as we see in this picture, and somewhat ligaments related to this structure. This is in the ulnar side of the wrist joint. Here the radius directly articulates with this scaffold, but the ulna is not directly articulating with any of the carpal bones. And in between the ulna and carpal bones, there is a fibrous structure and number of ligaments. This is called triangular fibrocartilage complex. And TFCC injury is common nowadays. And here, the pain will be in the ulnar side of the wrist joint. This is a patient with a TFCC injury, and here is the pain and tenderness side in the ulnar side, and supination is more painful. Any of the wrist movements are painful, especially supination. Investigation, the confirmatory investigation is MRI, or we can clinically diagnose the case. Here, advice avoid weightlifting and two-wheeler driving. That may cause further injury to the fibrocartilage complex. Management is bandage for 4 weeks. 4 weeks bandage is a must in case of TFCC injury. Then before that we can do Kashaya Dara or Dhanya Pradara initially, and after the removal of bandage we can apply Thaila Dara and Dasakugulu and Genta Thaila or Maharashtra Kashaya for useful in TFCC. And Brihat Sagaragruda form useful in TFCC injury. Or goat soup, we can use goat soup. Explained in Rajeshma Jigilsa. Sabipaligam Sayavam Sakulatam Samagaram Sadadimam Samaragam Snigdhamadharasam Tudil. That goat meat soup we can use here in TFCC injury. Then coming to Colles fracture. Is common in elderly women after menopause because the decalcification happens after menopause and fracture occurs easily. Followed to an outstretched hand is the cause, and fracture of radius within 2.5 centimeter of distal end. The Colles fracture is an extra articular fracture, and within 2.5 centimeter of distal end of radius the fracture happens. And There may be associated TFCC injury here. There may be associated TFCC injury. Investigation is X-ray, AP and lateral. And in Colles fracture, there is a dinner fork deformity because the radial part is displaced dorsally, forming the shape of a dinner fork. Coming to management, traction, reduction. And the important point is that keep the wrist of the patient in palmar flexion and ulnar deviation to ensure the position of bones. Here we can see an ulnar deviation is given and a palmar flexion is slight palmar flexion and slight ulnar deviation is given to the patient. Smith fracture is reverse Colles fracture because it is called so because the anterior displacement of the distal fragment of radius is here, just opposite to the Colles fracture. And there is Barton's fracture. Barton's fracture is rim fracture of the radius. We can manage the Barton's fracture if there is no displacement. Barton's fracture is intra-articular fracture, so take care of the displacement. If displacement is there, refer the patient. And then coming to scaffold fracture, in this X-ray we can see scaffold fracture. This is the fracture line. And X-ray wrist AP with ulnar deviation is helpful in detecting the fracture of scaffold. The peculiarity of fracture is that it is visible only after 10 days, usually. Tenderness in anatomical snip box. This is anatomical snip box, and tenderness in this area, anatomical snip box, is peculiar to scaffold fracture. Management is displaced proximal pole fracture. Care is a must. If the fracture is here, this is proximal pole and this is distal pole. If the fracture is here, that is proximal pole, it should be treated with internal fixation because the blood supply of the scaffold is like this. It is coming from distally and ends proximally. So fracture here will disrupt the blood supply and avascular necrosis will happen. And conservative management is for distal pole fracture. Distal pole is, if distal pole is fractured, conservative management is enough. And the bandaging, while bandaging, we should do it in a cup holding position. Cup holding position, this type of cup holding position is given for a scaffold fracture. And use Kanmadavasma to prevent the avascular necrosis. Kanmadavasma is found very useful in preventing avascular necrosis. If fracture is happening in scaffold, we should prescribe our Kanmadavasma to the patient. 2 BD capsule, Kanmadavasma capsule is available and 2 BD dose is enough. And coming to avascular necrosis of scaffold, this is, in this picture we can see the necrosed proximal part of the our scaffold bone after a fracture. The sclerosis is well seen here. Clinical feature is pain and tenderness in the anatomy of both the same area as in the fracture. Levels 1 to 3 months after the fracture. Management is open reduction and bone grafting in allopathy sector, and coming to our management, Dara with Brigat Panchamula Shira Kashaya initially for 5 days, then Thaila Dara, then Sneha Prayoga, Panam and Vasti. Sneha Prayoga is done with Sneha Pana and also in the form of Matra Vasti. Then coming to Sudex atrophy, this otherwise called complex regional pain syndrome, a condition of chronic pain following an injury. Pain, tenderness and marked swelling of the wrist, hands and fingers. In this picture, we can see marked swelling, and there will be tenderness and pain, and while flexing the fingers, there will be severe pain. This is after a Colles fracture. This condition is Sudex atrophy. And decalcification of carpal bones occurs. This is X-ray of the same patient. This is a Colles fracture case, and after 2 months, in this X-ray, we can see the decalcification compared to the former X-ray. Exact cause is unknown, but a dysregulation of central and autonomous nervous system may be the cause. In this X-ray, we can see the decalcification of carpal bones. Then management, Punardavadi Kashayam or Padanamatan Kashayam initially, then Chandraprabha Guguru, Kanchanara Guguru, Virajana with Nimbamra the Arandam is found useful in this case, and later Gandhadaira and Lasha the Guguru to increase the bone density. We already explained that there will be decalcification in carpal bones, so we should give Gandhadaira and Lasha the Guguru to the patient. And advice to reduce Amla, Levana and Shara in the diet. Also, we can use Nagara Dileva, Dhanya Muladara, or with Brihat Panjamula Siddha Shira, we can use Dara. And Panjamala Thaila Dara is found useful in reducing stiffness. Panjamala Thaila or Murugana can be used to reduce the stiffness. Next is Bandit's fracture. This is an intra-articular fracture. The base of thumb is fractured here, and it is called Rolando's fracture if it is comminuted. In Bennett's fracture, this is again this X-ray is presentation of Bennett's fracture, and if it is comminuted fracture of base of the metacarpal, it is called Rolando's fracture. In Bennett's fracture, only one-time reduction. We can try for one-time reduction because the pull of tendons is there. So, if the bone is reduced after one reduction, we can manage it conservatively. Otherwise, refer the patient for internal fixation. Then, Boxer's fracture or fourth metacarpal fracture. This we can manage with splint. Then phalanx fracture. All phalanx fractures except in intra-articular fractures we can manage easily with a splinted bandage. Then coming to common injury, mallet finger. Mallet finger, the reason is a rupture of extensor tendon. In this picture we can see the shape of this finger. This is mallet finger, and direct force will cause the rupture of extensor tendon and mallet finger occurs. Coming to the bandage or conservative management of mallet finger, 8 weeks blindage is a must. For 8 weeks, blindage is a must in case of mallet finger. Then ankle and foot. Coming to the anatomy, the tarsal bones are important. We can see talus, calcaneum, cuboid. It is somewhat tube-shaped, lateral cuneiform, intermediate cuneiform, and medial cuneiform, and metatarsals and phalanx. And coming to the ligaments, the medial side ligaments are called deltoid ligaments, posterior tibiotarsal ligaments, anterior tibiotarsal ligaments, tibiocalcaneal ligament, tibionavicular ligaments. These altogether called deltoid ligaments. Then coming to the lateral part, there are 3 main ligaments: posterior talofibular ligaments, anterior talofibular ligaments, and calcaneofibular ligaments. ankle sprain. This is one of the common injuries, and usually lateral ankle sprain is happening. It is more than medial ankle ligament sprain. Inversion is painful in lateral sprain and inversion is painful in medial sprain. Try to rule out avulsion fracture of the lateral, avulsion fracture of fifth metatarsal in lateral ankle sprain. This is a case of avulsion fracture of the base of the fifth metatarsal. This may happen along with the lateral ankle sprain. So we should rule out by just pressing this area. If there is tenderness, then take an X-ray and rule out the fracture. Management race regimen, that is rest, icing, compression bandage and elevation. Icing we can do with the ice cubes or either with in mild cases, 2 weeks bandage is enough. In severe cases, 4 weeks bandage may be needed. Then 1 week labana after the removal of bandage, labana with nagarati, and evening we can do dhanyamladara on the same day. Then after 1 week of labana and dhanyamladara, apply thailadara. Then coming to the mortis view of ankle joint. This is a special view of X-ray in case of ankle injuries. This is a normal AP view and this is mortis view. In mortis view, leg is internally rotated to 15 or 20 degrees. So we can visualize the dome of the talus and the lateral malleolus and medial malleolus very clearly. This is mortis view. In AP's view, there will be overlapping of the bones. So we should take a mortis view if we are suspecting a lateral malleolus injury or medial malleolus injury or pallar fracture. Then coming to bimalleolar fracture. Bimalleolar fracture is fracture of both of the malleolus, that is lateral malleolus and medial malleolus. We should refer this case. And the trimalleolar fracture, this is a fracture of the 3 malleolus because the lateral malleolus, medial malleolus, and one posterior malleolus is there in tibia, and 3 malleolus, 3 of the malleolus are fractured, and we should refer the case. Displaced bone fragments. If displaced bone fragments is there in any of the ankle fractures, please refer. And more than one malleolus is fractured, refer the case. It should be internally fixed. Then coming to talus fracture. This is talus fracture and there is displacement. So we should refer this case. Coming to calcaneal fracture. Calcaneal fracture, the mechanism of injury is jumping from a height or fall from a height. Here the calcaneum is comminutedly fractured. Here the comminuted fracture, we should go for internal fixation because shape of the calcaneum should be maintained. So we should refer the comminuted fractures. If just a crack fracture is there, we can manage by an edge splint and bandage with Murugana for 4 weeks. Then coming to metatarsal fracture. Here we can see the metatarsal is fractured second and third. In this case we can manage because there is no much displacement. We can manage this by splinting. for 4 weeks. Considering this case, we should refer the case because there is marked displacement. So cross union may occur in this case. It should be fixed internally. Then next is Joan's fracture. Joan's fracture is a fracture of the fifth metatarsal distal to the joint. Here we can see the fracture line. It is distal to the joint. Distal to the joint. This is called Joan's fracture. And Joan's fracture we can manage conservatively by splinted bandage. Here you can see the fracture line. And this is avulsion fracture of the fifth metatarsal bone. We already explained in the considering the lateral angle sprain. This is avulsion fracture of fifth metatarsal bone. Because the pull of the peroneus brevis tendon is causing fracture here. Pull of the peroneus brevis tendon attached to the base of the fifth metatarsal is causing this avulsion fracture. We can manage this fracture with a splinted bandage, L splint, and parallel splint, and an L splint is applied here, and we can manage it conservatively. And then coming to stress fracture of metatarsal bone. In this picture, the X-ray here, we can see clearly a fracture. This is a chronic fracture and happening by the repetitive stress in this area. This is also called March fracture or fatigue fracture. This is commonly seen in newly recruited police cadets or military army persons. And their calcaneum, there is chance of stress fracture in calcaneum also. Then coming to the plantar fasciitis, we can see the plantar fascia here. This is the attachment of plantar fascia to the calcaneum. This area will be inflamed in plantar fasciitis and inflammation will pass through the whole fascia. And degeneration of plantar fascia is the main cause here. And that is attachment to the medial calcaneal tuberosity. The attachment to the calcaneum is the common site of inflammation in case of plantar fasciitis. Pain in the heel is the clinical feature. More in the morning because the foot is plantar flexed during sleep. And sudden stretching of the fascia by walking or standing will cause pain. Then coming to the management, Padanamradam Kashayam and Velaguluchari Kashayam found useful. It is purely a Vadarakta condition and Google-Vitta Kashaya we can use. Shirabala Avarti, internally we can use. Amardashtam Puranavasam we can use initially. Vettumaran or Rasasinduram in severe pain we can use. Considering the Rasasinduram capsule, Rasasinduram has a capability to increase the activity of any other medicines which is using along with it. So we can use Rasindura in any inflammatory conditions with other anti-inflammatory drugs. It is very useful. You can try it. Then Tabasvedam is found useful in plantar fasciitis. Pindasvedam with Nagaradi Labachurna. Nagaradi Labachurna or Kotanchukadi Churna we can use as Pindasvedam, not directly applying on the skin, but we are using Pindasveda, Churna Pindasveda by Nagaradi or Kotanchukadi Churna here. It is found useful. Then Agnigarma, we can use Agnigarma treatment in plantar fasciitis. We all know sittings, 5 or 6 sittings may be needed. Then coming to retrocalcaneal bursitis. Here we can see the Achilles tendon and the bursa. Here is the retrocalcaneal bursa and inflammation of the bursa is called retrocalcaneal bursitis. It is a common condition. In this patient, we can see here a swelling. Here is this is a case of retrocalcaneal bursitis. This is a site of bursitis. Then coming to Achilles tendinitis, we can see here the Achilles tendon is inflamed. Both of these cases are same in the concept of in management area. That is, Labana with Jadamaya Rizuna is more effective because it is Vadraktara. Jadamaya with Churna Laba is more useful in retrocalcaneal bursitis and Achilles tendinitis. Then Snigdha Pindaswara with crushed sarshava and red chilies. Red chilies in Malayalam called Kandari, especially is found very useful. That is sarshava and red chilies. With Muruvana or Bela Gulichai Thailam, we can use as Snigdha Pindaswara and Apnigarma in chronic cases. And coming to Seamus disease, it is seen in children more commonly, and here in this X-ray we can see the epiphysis of calcaneum is more detached, or there is a gap in this area, and here we can see also increased density. This is typical of Seamus disease. It is caused by repetitive traction injury of the Achilles tendon. Achilles tendon is attached here, and pull of the Achilles tendon cause this inflammation, and this is called Seamus disease. This is usually affects 6 to 12 years aged children, and chronic pain will be there in the hip. Coming to management, rest for 2 weeks is enough. Bandage with Muruvana is found very useful. We can bandage the patient for 2 weeks. Then India, Ganthathaila and Lasha Gugulu, and Gugulita Kashaya or Gugulita Kashaya we can use here. And coming to OA of talocalcaneum, here we can see the junction of talus and calcaneum. This is osteoarthritic region in this X-ray. We can manage, as we all know, the management is same as osteoarthritis of other joints, and especially bandaging will help in this case. And OA of the talonavicular, here we can see the joint space is collapsed here. And coming to tarsal tunnel syndrome, or it is called the entrapment neuropathy of the posterior tibial nerve. As in the carpal tunnel syndrome, here the flexor retinaculum is stenosed. Flexor retinaculum is inflamed and causing the stenosis of the tarsal tunnel, and the posterior tibial nerve is passing through this retinaculum, and the symptoms occurs as the entrapment happens. Pain and numbness and pins and needle sensation will be there in this area, and there will be a weak toe of flexion. Another condition is Morton's metatarsal. Coming to the management of tarsal tunnel syndrome, same as carpal tunnel syndrome, the principle is same in every entrapment neuropathy. Then coming to Morton's metatarsalgia. This is a common case coming to our OPDs, and neuroma is a case is neuroma of the plantar digital nerves. In this picture, we can see the nerve branches, and here the neuroma is causing tension along the intertarsal ligaments. We can see clearly the intertarsal ligament is break here, and the neuroma is causing pressure effect on this area, and pain and tenderness will be there along the metatarsals third and fourth metatarsals. The pathology is entrapment of nerve under the intermetatarsal ligaments. And pain, burning sensation, and numbness along third and fourth metatarsals will be the resulting, and increases by barking and increases by rest. The symptoms increases by walking, and rest will reduce the symptoms. It is common in middle-aged females. Examination. While examining, give deep palpation in intermetatarsal area, and it will provoke the pain. This is a diagnostic for mortis metatarsalgia. And coming to the management, Kanjana Gugulu, Varanadi Kashaya, and Chandraprabha Gugulu found useful, and massage with liniments. Liniments are somewhat muksha compared to thylas, and we can use liniments in this case of mortis metatarsalgia, massage along the metatarsals and in between the metatarsals will help to relieve the condition. And Lebana with Nagaradi or Kartha will be useful, and advice to avoid the heels, high heels. High heel couples will cause more pressure to the metatarsals and condition worsens. And Yaktamoshna by Prachana is found useful in mortis metatarsalgia. And in considering the ankle joint, there are so many tendons passing beneath the medial malleolus or lateral malleolus. We should take care of the tendons because the local pathology of tendons may cause severe pain, and we misdiagnose this pain as bony or joint pains. So we should examine tendons like posterior tibialis tendon and peroneal tendon. Peroneal tendon is passing in the beneath the lateral malleolus. You can see here peroneal tendon. There are two peroneal tendons passing through this area. The tendinitis may cause pain along this area. This area will be pain in case of peroneal tendinitis, and flexor hallucis tendinitis. This is medial side tendon, and pain and inflammation along the tendon may be there. So we should examine each tendon carefully while considering the pain of ankle joint. And this is posterior tibialis tendon. This is also medial side of the ankle joint. Pain and tenderness will be in this area. Tendinitis, all tendinitis are treated anti-inflammatory line, and Dhanyamadara initially, and then Thailadhara with Muruganna or Dhanandra Thaila in later stages will be useful. Then coming to gouty arthritis. All we know, the common site of gouty arthritis, one of the common site of gouty arthritis is the metatarsophalangeal joint of the big toe. Here, severe tenderness and burning sensation and severe pain will be there in gouty arthritis. And coming to the management, Vadartara Chikitsa is helpful. Also, use Sofhara treatment line here. Manjistari Kashaya found useful. While using Manjistari Kashaya, we should prescribe Alpathic Murna or Madhivadra Kula along with that for more results. And juice made from core portion of banana stem is very useful. This is Unnipindi in Malayalam, and it is found very useful if taken in half glass daily dosage. And Punanavadi Kashayam found useful, Chandraprabha Guru, then Viryajan with Nimbramada the Eranda is very good in case of gouty arthritis. And this is a case of rheumatoid arthritis. The management is same as we explained before. And congenital abnormalities is coming to club foot. This is congenital abnormality, and surgery is a better option. Bandage may help somewhat degree, but surgery is better in clubfoot. And this is flat foot. And arch formation never happens in growing time. This is the reason for flat foot. Also, there may be cases with adult arch foot that is developing after adulthood because of the long-standing job or weightlifting job, repeated stress with the foot cause flat foot in adults, and arch formation deformity will cause the flat-footed children. And also, flat foot may associate with neuromuscular diseases like polio. Then claw foot. Claw foot is otherwise called high arch foot. This is also associated with neuromuscular diseases. And hallux valgus or bunion. The cause is tight shoes in growing period, and rheumatoid arthritis may cause this hallux valgus. Surgery is the treatment for hallux valgus. You can reduce the pain if there is such symptoms. You can reduce the pain and inflammation related to this joint by our medicines. And hallux varus, it is by congenital or by injury or rheumatoid arthritis may cause hallux varus. And coming to sesamoiditis, sesamoid bones are bones formed inside the tendons. The largest sesamoid bone is patella, all we know, and inflammation around the sesamoid bones cause severe pain and tenderness. And we can manage by using anti-inflammatory drugs. And coming to osteomyelitis of calcaneum is a case. In this X-ray, you can see the disruption of the periosteum and infection in the calcaneal bone. Fresh cases of osteomyelitis should be referred for antibiotic treatment. In chronic cases, our treatment is improving the condition. Gugulita Kashaya and Gugulita Grida are found useful. Yasa Sindura with Trifala Gugulu. Sindura with Trifala Guru. That is Pranahara Chikitsa we can use in case of osteomyelitis. If it is chronic, acute cases we should refer. And Gugulu Panchavala Churna ideally with honey and dressing with the Jati Taila will be useful. Thank you.
Hello. Hello, dear friends. Have any question or any doubts regarding the session? You please ask directly. Please unmute your mic and ask directly. Or otherwise, you can type a message in our chat box. Hello.
Namaskaram, sir.
Okay.
Sir, can you elaborate treatment regarding calcaneal spur? How to approach the patient, sir?
Okay.
Calcaneal spur.
Calcaneal spur is usually seen in case of plantar fasciitis. Yes. This area, there will be a spur, bony spur, forming after chronic inflammation. That's called calcaneal spur. or heel spur. And in my experiences, already the spur is not causing the pain. The inflammation is causing the pain. So the X-ray, in X-ray we can see spur, but don't worry about the spur, but treat the inflammation, and we can treat the inflammation with our anti-inflammatory drugs, like starting from Amrutotram or Pajanamrutam Kashayam, then use Kanjana Gugulu or use Vettumaran along with that, then use Amrutashtam plus Punarnavasam initially, and use Tapasveda along with that. Then after 2 weeks of initial this type management, we can start Thaila, internally Thaila application. So internally we can take Shirabala Thaila or Gandha Thaila. Shirabala is more useful. We can take 10 drops BD, and along with that we can start Agni Karma. Weekly. After 2 days of Tapasveda, we can start Agni Karma. After reducing the inflammation, we can start Agni Karma and medicines with internally like Shirabala and Gandha Thaila. Also change the Kashaya to Gugulu Tiktaga or Rasneratadi. Then initial management, the inflammation is reduced, then we are using Thaila.
Thank you, sir.
The spur is actually not causing the pain. Inflammation around the spur is causing the pain. So don't worry about this spur.
Thank you, sir.
ज्योति आ जाना आज खांसी से कुछ आराम हुआ है कोड़ी खा गया
Hello, Namaste, sir.
वो भी खाने आए थे
Yes, sir.
Hello.
बहुत
Sir, can you explain the treatment for rheumatoid arthritis, sir?
आने जल्दी आना
Which joint you are asking for?
Wrist and ankle, sir.
Okay.
There will be severe pain in the metatarsals.
Then Vadrakta treatment. In severe cases, we should go for an IP management. IP management is a must in Vadrakta severe cases. In that case, we can start with Snehabana. Snehabana with Gupilchita Gruda, either with Gupilchita Gruda or with Mahanarayana Thaila or Dhanvendra Thaila. We can start with Snehabana after attaining proper acne. Then for Virajana, we should use Nimbamada the Aranda. After Svedana, we should use Virajana with Nimbamada the Aranda. Then we can go for